Thank you very much for that kind introduction. I hope it was a kind introduction. Was it a kind introduction? Okay. Thank you for the kind introduction. It's also thank you for to the organizers of the COPA meeting. It's a great meeting. It's great to be back in Brazil. I think it's my 8th time and one of my favorite places in the world. It was just at the Iguaçu Falls, fantastic place. Has everybody been there? No, only the tourists. So in any case, my practice is in pediatric cardiac anesthesia and intensive care, and my research is, my lab is doing clinical pharmacology and immunology, also largely related to congenital heart disease. So today I'm just going to speak for a short time about taking care of children and, of course, adults who have congenital heart disease, who are having non-cardiac surgery, and they may or may not have had a cardiac repair. And I know that you see these patients sometimes even at a later stage than we typically do, with very advanced signs and symptoms related to their congenital heart defects. So I think as in Brazil, even in California, cardiac surgery for children is performed only in a small number of centers. And so many of us, even in California, may be very far away from these centers, and I'm sure in Brazil this is certainly no different. And so children who are having surgery, or even adults with congenital heart disease having non-cardiac surgery, don't necessarily go back to the center where they do the congenital heart surgery. They may be having surgery at your local hospital for a variety of non-cardiac surgeries. So I think that we all, as anesthesiologists, need to understand at least the basics of congenital heart defects, how they present in children, and also more and more, of course, we're seeing adults as we are better at managing these congenital defects in babies and children. More of them are growing up to become adults. They're becoming pregnant and having babies. They're getting older and having problems associated with middle age. So this is a really evolving clinical scenario. First of all, we have to be able to organize the way we think about congenital heart defects, and this can be very challenging. And so it's important, I think, to have a framework in our mind for approaching what may seem like a very complex congenital heart lesion. And I would recommend that we sort of organize our thoughts into 4 categories. And of course, the congenital defects may not be discretely in one category, but many of them are associated with shunts. And that means they have holes or connections between arteries and veins that are not supposed to be there, so they have blood flowing either from left to right, as we say, or from the red blood to the blue blood compartment, or right to left, blue blood flowing into the red blood compartment. So we can think of what the shunt lesion is, if any. Of course, many of you are very familiar with dealing with obstructive lesions, both on the pulmonary side and also aortic valve stenosis, for example. Myocardial dysfunction, we just heard about right heart function. So these patients with congenital heart disease may have residual left and or right-sided dysfunction as a primary problem, or possibly a sequelae of their congenital heart disease, possibly related to previous surgery. And of course, arrhythmias are not uncommon in these patients, either as part of their primary diagnosis, such as a complete AV canal, or transposition of the great arteries, what we call corrected transposition, high incidence of heart block, or patients as a result of surgery that is near the conduction system, for example, ventricular septum. So beside thinking of shunts, obstructions, dysfunction, arrhythmias, we can also try to organize our thoughts as to whether the patient is pink, and therefore if they have a shunt lesion, it's a left to right shunt, or are they cyanotic or blue, that is, if they have a shunt, it's from right to left. And I'll just focus in my brief time on 2 of the more common diagnoses in each group, and that would be ventricular septal defect for patients that typically have a left to right shunt. That means red blood is going into the blue blood compartment, And then on the right to left shunt or cyanotic side, tetralogy of Fallot is probably the most common congenital lesion associated with right to left shunt. So I'll just make a few comments about ventricular septal defects and tetralogy of Fallot as examples. First, the most common congenital heart disorder among children is ventricular septal defect. And these patients, of course, have a hole in the ventricular septum, and generally the blood is going from the left ventricle through that hole into the right ventricle. So this is a left to right shunt. The patients are not generally cyanotic, but if this hole is large, then they may develop congestive heart failure. If the hole is very small, we may call it a restrictive ventricular septal defect. That means that the pressure in the left ventricle is higher than the pressure in the right ventricle. Usually those patients are not so sick, even though they may have a very loud heart murmur. And the problem with ventricular septal defects is that there's volume overload in the right ventricle. We heard about right heart dysfunction, so these patients will develop volume overloaded right ventricles because the right ventricle has to pump all of the blood, both coming back from the systemic venous circulation out the pulmonary artery, and then all the red blood coming back from the lungs to the left ventricle. A fraction of that is also entering the right ventricle. So the right ventricle has to pump all of the systemic venous return and then some of the pulmonary venous return as well. So the right heart has volume overload. The consequence of chronic left to right shunts, for example with ventricular septal defects, there's too much blood going to the lungs. So we say that the QP-QS is elevated. The pulmonary blood flow to systemic blood flow ratio is more than 1. And these patients, as a consequence, develop not only right-sided volume overload, but also left-sided volume overload. And then they may develop congestive heart failure. The signs of congestive heart failure in infants would include tachypnea, sweating, retractions due to pulmonary edema, and then failure to gain weight and to grow. So pulmonary edema, of course, you're all familiar with patients who may have left heart dysfunction and develop pulmonary edema. That is also a principal finding in children and adults with ventricular septal defects. Children will have poor weight gain, poor linear growth. The treatment, like adults with left-sided heart failure, is with medications, including digoxin, diuretic therapy, and drugs that reduce systemic vascular resistance, such as captopril. And that will diminish the left to right shunt. So if we decrease the systemic vascular resistance, there will be less of a gradient favoring blood going across the ventricular septal defect from left to right. So after load reduction, if the patients do not respond to digoxin and diuretics alone, would be a principal therapy. And then, of course, these patients have electrolyte imbalances related to diuretic therapy. They have contraction of their arterial blood volume, just like adults with chronic hypertension. So a little bit of anesthesia, they get vasodilated, they may become very hypotensive very quickly. And then if the ventricular septal defect is not repaired, these patients may develop Eisenmenger syndrome because there's too much blood going to the lungs. The small arteries in the lungs are chronically vasoconstricted, they become very muscular, and eventually the pulmonary vascular resistance may become even higher than the systemic vascular resistance, and now the blood across the VSD switches direction. Instead of left to right, when the pulmonary vascular resistance is very high, the blood is now going from right to left, and the patients become progressively cyanotic. For cyanotic lesions, as I said, the most common congenital heart defect causing cyanosis is probably tetralogy of Fallot. And you can see here the 4 principal findings in tetralogy. What you have is a ventricular septal defect here, and it is called a malalignment ventricular septal defect. It is right underneath the aortic valve, and so the aorta is said to be overriding. That means it sits right on top of this ventricular septal defect, so both chambers may be pumping blood into the aorta. There is thickening of the right ventricle, again because of the left to right shunt initially, although the shunt may be bidirectional. There's also outflow tract obstruction, some degree of pulmonary stenosis, and this causes the right ventricle to become very thick-walled and hypertrophy. The variability we see in patients with tetralogy, they all have this malalignment VSD, they all have an overriding aorta, they all have a thick right ventricle. The variability that we see is related to the degree of obstruction in the right ventricular outflow tract. So it can be infundibular obstruction. The pulmonary valve may be very small. It may actually be atretic. Then we say this is tetralogy with pulmonary atresia. That would be on the worst side of the spectrum. On the more favorable side of the spectrum would be a normal-sized pulmonary valve and simple, mild to moderate infundibular obstruction. Those patients can have a procedure where the infundibular muscle is resected without changing the pulmonary valve, without cutting across the valve, and the ventricular septal defect is repaired, and they do very well. The patients with pulmonary atresia, on the other hand, are much more complicated, and they may end up with permanent cyanotic heart condition. The longer-term complications of having a cyanotic lesion with right to left shunt are chronic hypoxemia. These patients are cyanotic. As a result of that, they have an increase in their minute ventilation, they have tachycardia, they may have increased cardiac output to try to deliver adequate amounts of oxygen to the tissues. And so over time, they have some degree of heart failure. They have decreased blood flow to the organs in the body, and the blood that is there is desaturated, cyanotic, and so there's poor oxygen delivery to the tissues. The children will then have poor linear growth and poor weight gain. And also remember, in patients with cyanotic heart disease, the blood flowing through the coronary arteries to the heart muscle is also blue. So these patients have a perfect storm, if you will, of disadvantages. They have thick right ventricle in the case of tetralogy, increase in myocardial oxygen consumption, and poor delivery because the coronary blood flow is with cyanotic blood. These patients will develop polycythemia. I'm sure that any of you have taken care of children in Brazil who come from far away from the cities. They present late. They may have a hematocrit of 70 or 75% in some cases. And they also have poor coagulation function. So if you're taking care of a patient like this who's having an orthopedic operation or an abdominal operation, they may have excessive blood loss. Another complication of right to left shunts, of course, is that there may be what we would call paradoxical emboli. That is either a bubble going across from the right atrium or right ventricle to the left side of the circulation and lodging in a coronary artery, causing a myocardial infarction, or that little bubble may travel out the aortic valve into a coronary artery, causing, into a cerebrovascular vessel, causing a stroke. If it's not a bubble, but instead it's a little bit of infected material, they may have paradoxical embolization with bacteria and develop a brain abscess if that bacteria goes to the central nervous system. You may have seen patients with clubbing as a complication of chronic right to left shunts or cyanosis, and this is certainly a bad sign. So if you see somebody with clubbing due to congenital heart disease, you should be very concerned that they have the other complications as well. Coagulopathy, chronic hypoxia to many organs of the body, and both right and left myocardial dysfunction. The patients who have, for example, a chronic left to right shunt from a ventricular septal defect, as I said, may develop progressive thickening of the media of the pulmonary arterioles, an increase in pulmonary vascular resistance, and this becomes a runaway process so that the pulmonary vascular resistance may actually become higher than the systemic vascular resistance, and then the blood is shunted not left to right, from left ventricle to right ventricle, but eventually from right ventricle to left ventricle. And this is called Eisenmenger syndrome, and those patients, of course, will have all of the signs and symptoms we talked about associated with cyanotic congenital heart disease. This is a contrast echo in a patient with pulmonary hypertension, Eisenmenger syndrome. This is a patient that's had a repair, but despite that went on to develop increasing pulmonary vascular resistance because the VSD was closed very late. There's a bit of a residual atrial shunt, so you can see when agitated saline is injected rapidly into an upper extremity vein, normally you would see the contrast going across the tricuspid valve and then pretty much disappearing because the pulmonary capillaries would eliminate that agitated saline and you would not see the contrast showing up in the left atrium, left ventricle. But in a patient with Eisenmenger's who has a patent foramen ovale, what you may see is that the contrast enters the left atrium and left ventricle very quickly. And this is, of course, a very bad sign. So we talked about left to right shunts with a ventricular septal defect, right to left shunts with tetralogy of Fallot or Eisenmenger syndrome, for example. And the next category would be obstructive lesions, and you are familiar with patients with aortic stenosis. The most common cause of aortic stenosis is a bicuspid aortic valve. So you may have seen patients with a bicuspid aortic valve. Coarctation of the aorta also is a very serious long-term problem. These patients develop hypertension. They may have aortic dissections even after they are repaired. Pulmonary stenosis, pulmonary hypertension itself is considered an obstructive lesion. And of course, these patients may also have shunt lesions. So as we said, we may see patients with pulmonary hypertension due to Eisenmenger syndrome and a persistent ventricular septal defect. So you may see combinations of shunts and obstruction either on the left or right side of the heart. Just say a word about coarctation because you probably have seen patients with coarctation. They may have already been repaired, but even so, they may develop chronic hypertension. They have a heart murmur if they have residual or recurrent coarctation that goes to the back. They have diminished pulses in their lower extremities. Chest X-ray shows because of collateral circulation through the intercostal arteries, they have little notching in their ribs. And the main thing I want to emphasize is that many of these patients have recurrent coarctation. So if you have a patient that's had a coarctation repair, be suspicious that they may have recurrence, they may have hypertension, they may have complications of recurrent coarctation. And if they do, they can have balloon angioplasties in many cases. So besides shunts and obstructive lesions, many patients with congenital heart disease have myocardial dysfunction. You're all very familiar with systolic dysfunction resulting in poor contractility. This may be due to myocardial ischemia from previous surgery, for example, or it may be due to a persistent cyanotic lesion with cyanotic blood perfusing the heart via the coronaries, causing chronic ischemia and dysfunction. They may have chronic volume overload from a ventricular septal defect that's not repaired, for example. They may have only one ventricle. And if they have hypoplastic left heart syndrome, for example, even though they have a number of staged palliative surgeries, the right ventricle is functioning as a systemic ventricle, and this generally will result in heart failure by the age of 20 or 30, certainly, because the right ventricle is not designed morphologically to sustain systemic output for a lifetime. Also, though, besides systolic dysfunction, you should think about diastolic dysfunction, because this is very common in patients with, for example, right ventricular hypertrophy from tetralogy. These patients may have normal systolic function, so their systolic blood pressure may be normal, but during the relaxation phase, the heart is very stiff and does not fill normally. And this will result in pulmonary edema from left-sided diastolic dysfunction and congestion in the body from right-sided diastolic dysfunction. So beside having ventricular dysfunction, you should have a way of rapidly assessing in your mind, remembering what other coexisting cardiac issues can result in low cardiac output. So of course, myocardial failure would be poor contractility, but as we heard in the talk about right ventricular failure, The heart rate may be too fast or too slow. That causes low cardiac output. The patient is not in sinus rhythm. Inadequate preload and excessive afterload, all of these can occur in patients with congenital lesions. I just want to say a word about this one particular disorder because I think it is one of the most deadly congenital disorders that we see in both children and adults. And sometimes these patients we underestimate how sick they are. So patients with Williams syndrome, how many of you have seen patients with Williams syndrome? So these patients may present with a relatively unusual lesion, and that is aortic or pulmonary stenosis that is supravalvar. It's above the valve. So this is not the usual location for aortic or pulmonary valve disease. So beside the supravalvar lesions, they may have stenosis of the pulmonary artery branches, but this is not a focal disorder. Williams syndrome is associated with a diffuse disorder of collagen, and so these patients have angiopathy or abnormalities in all of their arteries in the body, including their coronary arteries. So during times when myocardial oxygen consumption is increased, such as in a child having mask induction of anesthesia, we know that patients undergo a stage during induction where they have elevated heart rate, they may have an elevated blood pressure, they may have myocardial ischemia if their coronaries are abnormal, such as with Williams syndrome. And also during emergence from anesthesia, these patients will again have increased myocardial oxygen consumption. And if their coronaries are abnormal, associated with Williams syndrome, they may also have ischemia and cardiac arrest at that time. And this includes patients with Williams syndrome who have no cardiac symptoms at all. So if you see a 5-year-old or a 12-year-old or an 18-year-old patient with Williams syndrome who's having a hernia repair, I would be very concerned and try to have one of your colleagues take over the case, because these patients have a high rate of morbidity and mortality, intraoperative cardiac arrest. Even in patients who have repaired congenital heart defects, you should be very concerned that they may have residual obstruction, they may have some pulmonary hypertension, they may have myocardial dysfunction, they may have arrhythmias. So it's very important to take a careful history, and this is where the preoperative assessment becomes very crucial. I would say if you have a patient with congenital heart disease coming to you for preoperative assessment, the history may be the most important thing. So does the patient have a normal exercise activity? Do they have a history of palpitations or syncope? Obviously, you would want to know if they had a previous cardiac operation. On the other hand, if it's a patient with a simple ventricular septal defect that is small and restrictive, they may have minimal risk for anesthesia and surgery. So they may have a loud murmur, but a very small ventricular septal defect. They have normal exercise activity, then the anesthetic risk is probably very small. They do not need to have had an echo in the last 6 months, for example. So if the family tells you that, yes, my son has what the cardiologist says is a very small ventricular septal defect, but they run around with their peers and their friends, they've had no problems with palpitations or syncope or heart failure, they've never had surgery, they're not taking any medications for heart failure, you listen to them, they have a loud murmur, but they probably do not need additional workup at that time. It is probably safe to go ahead, provide anesthesia for a simple superficial operation. On the other hand, if they have a history of surgery, heart failure, they're taking heart failure medications, then they should have a recent cardiology evaluation. I would want to see an EKG and an echo report at a minimum. As far as providing anesthesia for patients with shunt lesions, the anesthetic may have a significant impact on their shunt. So I mentioned before that we think about the pulmonary blood flow to systemic blood flow ratio, or what we call the QPQS. Our anesthetic may change the pulmonary vascular resistance compared to the systemic vascular resistance, and this will have an impact on the magnitude of the shunt. So if the patient has, for example, a ventricular septal defect, and we do something that causes their pulmonary vascular resistance to increase, this may cause an increase in right to left shunting. So this may cause more blue blood going from the right ventricle to the left ventricle, and the patient's oxygen saturation may drop. Causes of increase in pulmonary vascular resistance could be light anesthesia, could be hypothermia, could be that they're being underventilated and their CO2 is high, because of course CO2 causes pulmonary vasoconstriction. So if you see this phenomenon, the saturation is going down, your endotracheal tube is in good position, the lungs are being well ventilated, you may simply need to increase your ventilation to decrease the pulmonary vascular resistance. If you're using PEEP that is too high, that may also increase the pulmonary vascular resistance. Similarly, we should think about how our anesthetic might affect the systemic vascular resistance, because this also may change the left to right or right to left shunt. So I think I'm going to finish there. Maybe we have a minute for questions. I'm not sure if that's allowed, but I have a few more minutes in my 30 minutes. But I hope that I've at least been able to explain to you some of the basic considerations of how to organize your thoughts, do a good history and physical, decide whether you need more laboratory tests like an echocardiogram, to be able to plan your anesthetic so that you maintain normal pulmonary and systemic vascular resistance, that you have in your mind complications related to heart failure, cyanosis, arrhythmias, and that you can take good care of these patients with congenital heart disease who are presenting for non-cardiac surgery. And I think that if you keep your eyes forward, you keep your thoughts very well organized, then you will have good outcomes. And I will stop there, and thank you very much for your attention.